objectives. So the goal of this talk is to recognize and clarify some misconceptions about obesity, explain the definition diagnosis of obesity, comprehend the genetic factors of obesity, know the anthropometric components of obesity medicine, and understand the clinical components also. Okay, so let me just great. So let's talk, the first myth. So obesity is a choice, not a disease. Is this a myth or a fact? So, well, this is a myth. So obesity is a chronic disease. So it's not a choice like many people think. So it's a chronic multifactorial neurobehavioral disease where there is an increasing body fat that promotes the adipose tissue dysfunction, resulting in adverse health consequences. So I think it's very important to let our patients know that it's not just because they don't stop eating or they don't exercise. It's really, really a chronic disease, and we are here to help them. There is a lot of consequences, as we know. Um, Probably alongside with the COVID-19, unfortunately, obesity medicine is another pandemic, not just in the US, but in the whole world. So the adverse metabolic consequences that we can have because of obesity is high blood pressure, diabetes type 2, high cholesterol, triglycerides. The biomechanic consequences, we have obstructive sleep disease, we have osteoarthritis, back pain, cancer, DVT, carpal tunnel syndrome. Because of all the mass, it can compress and it can cause that weight and cause all these diseases. And psychosocial consequences, right? So the low self-esteem, so you ended up having depression, anxiety, panic attacks, and bullying because people just don't understand. So let's talk about the weight. So what obesity is, right? So actually obesity is classified, is based on the BMI. So a normal weight is like 18.5 to 24.9. So everything 25 and above is already overweight. Obesity is when your BMI is 30 and above. And then we have a classification. We have class 1, 2, and 3. Class 1 is 30 to 34.9, like is here on the slide. 2, 35 to 39.9. And class 3 or severe obesity is when the BMI is above 40. For childhood is a little different because it's all about percentile on the growth chart. So for the overweight kid is when the BMI percentile is above 85, and then obesity 95, and severe obesity 99 percentile. So there is a little difference in BMI according to the region. So China, Japan, India, so the overweight is a little lower. So in the West region is basically when it's 25 and above, and then for overweight, and then on these regions more on the east side of the world is a little below. Why? Because the diseases, the consequences started a little when the BMI is a little lower. So we need to be very, very careful with this population because the problems, the medical problems, started like when the BMI, when we think the BMI is normal, but actually is not. So another thing that is important also to mention is about the waist circumference. So that's another very good predictor of metabolic syndrome. So if sometimes the BMI is very helpful, but when the BMI is above, is 30 to 30 or above, 35 and above, then is where the waist circumference is very, very good to predict if you're going to have like a metabolic syndrome soon. So for men, so that's going to be classified according to gender. So for men, is the 40 inches or 102 centimeters and above. And again, on the population of South Asians, Chinese, Japanese is a little lower. And so it is when you're going to have a prediction of metabolic syndrome. Same thing for Europe, a little lower than on the West region. So this is for women. So women is 35 inches or 88 and above. And for the South Asians, Chinese, Japanese, little lower. Also, same thing with Europe. So they are the same number as Europe and Asia. But very important to know. So there is a difference between checking the waist circumference. So usually we ended up going to the WHO, which is above the iliac crest, so you can do the NIH recommendations, which is in the middle at the iliac crest. Okay, so another myth or fact is obesity can be attributed to genetics. Is that a myth or a fact? Well, that's a fact. So in 2007, a genome-wide association study identified the fat mass and obesity associated gene, which we call FTO. And it is established obesity susceptibility locus located at the chromosome 16q12.2. So what they found out is that this gene, if you have this gene, you have a higher chance to have the disease of obesity. So again, it's not just about the behavior, it's about also genetics. And the thing that is associated with this gene is that the controlling of feeding, right? So you just eat, and it's kind of hard to control, and there is a lower energy expenditure if you have this gene. So here is a very good example. Sorry. Yes. So an individual that carries one copy of the FTO allele can weigh 1.2 kilos more than an individual without. And if a person carries two copies, they can weigh 3 kilos more than an individual with no copies at all. So that's important, just to see like how the genetics also can attribute to the obesity, the disease of chronic obesity, this chronic disease. So that's the next one. Myth or fact, being overweight is never healthy. Yeah, that's actually true. So let's go and talk a little bit about that. So for a person with a BMI of 25 and above, each 5 kilos, let's say each 5 points on the BMI, that there is an increase. So if I have like a BMI of like 25 and above, and then increasing 5 points in 5 kilos millimeters, the BMI is associated with 30% higher mortality. Okay. It's also associated, like we talked before, with lots of chronic diseases like cancer, diabetes type 2, hypertension, thrombosis, very related with blood clots because of the weight, the compression of the fat mass. And also, to every 1 kilo of weight gain, the risk of developing diabetes type 2 can increase by 9%. So here is just showing that it's never healthy being on the overweight side. So the fat mass, what is a fat mass? Is basically increasing the body fat, right? So it's very straightforward and results in these abnormal and pathological physical forces. So the fat mass compress everything. So you have the obstructive sleep apnea, you have the CHF, you have the reflux, the GERD, the hernias, the arthritis because of all that weight on the joints. The sick fat adiposity, the adiposopathy, is described as an unbalanced adipocyte and immune response, which occurs secondary to adipocyte hypertrophy when abdominal obesity is present. So this is more like an immune response from the sick fat, and or we call adiposopathy. And that's when we have kind of like the result of that, let's call like inflammation, which is not really inflammation, but it's just like the immune response from that excess of sick fat, which it can cause cancer, high blood pressure, metabolic syndrome, fatty liver, gout, and diabetes type 2. So this is just a few examples to show how being overweight is not healthy. Is that if you're overweight at age 40, you live around 3 years less with a person with a normal BMI. At the BMI of 30, 35, the survival median is reduced by 2 to 4 years. A BMI of 40 to 45 is reduced by 8 to 10 years, the life expectancy. And this is comparable to smoking, just to see how bad it is. Those with both obesity and smoking, so if they do both, then they live way less, which is 13 to 14 years less than normal weight, than don't smoke. And also individuals that they have the metabolic, like they reported metabolic healthy. So for example, they don't have any of these metabolic diseases, but they have obesity. They have a higher rate of like heart disease, obstructive sleep apnea, damaged joints, and the risk, of course, of developing metabolic syndrome in the future. So what it means is that a lot of people like, hey, my weight is high, but I don't have any medical problems. So it's like, well, not now, but the chance for you to have in the future is higher. Okay, another myth or fact. Obesity is not associated with sleep. This is a myth because it's very, very associated with sleep. So let's talk about a little bit about the sleep. So sleep's the most sedentary activity, yet is the only sedentary activity that protects from weight gain. I really, really like this statement because it's so true. That's the only sedentary activity that you can do as much as you want. So WHO and CDC, they recommend 7 to 8 hours of sleep at night. And if you sleep like any adult, they sleep like 5 hours or less, they have a 55% chance of having obesity when they compare with people that sleep more than 5 hours a night. Every additional hour of sleep decrease the incidence of obesity by 30%. That's a lot. And if a person sleeps less than 6 hours, the increased probability of obesity can be by 6%. And if you sleep like from 8.5 hours to 5.5, you burn less calories. So it's just like burn like 400 less calories if you sleep 8.5 hours compared with 5.5. So what it just showed to you is that how much sleep is important for like many, many reasons, but also to help, to lose some weight. Like I said, is a very good and maybe the only sedentary activity that you can do as much as you can. I'm not saying that you're going to sleep the whole day, but if you have a good night of sleep, it's going to help you lose weight. So this is all the benefits from the sleep. So if you sleep like 6 to 8 hours per night, which what is recommended is 7 to 8, but even 6 to 8 hours, you're going to have a better mood, better ability to focus, decreasing daytime sleepiness, more willingness to exercise because you're going to have more energy, not going to be as fatigued. You're going to have a decrease in caffeine intake, which is very good, for your health. So you're not like dependable on the caffeine. Less cravings for sweet and salty foods in the evening. So if you have a good night of sleep, you're not going to have that craving just for the junk food, for that food like high in carbs, which is just going to mess it up everything with you at night, because that's the time that you start burning your calories. And if you just eat lots of carbs and sugars before you sleep, it's just not going to be as beneficial. And lower risk of major cardiovascular events and deaths if you have a good night of sleep. So A reduction of 1 hour of sleep is associated with 0.35 increase on your BMI. This is just more evidence about how good sleep is. Children who sleep less than 10 hours per night have 89% greater risk than their colleagues to have obesity. Morning individuals type have a lower BMI than evening individual type. So the morning is like, the morning person that wakes up early and doesn't have any issues with mood and is happy in the morning. And then the evening individuals are the ones that like to work or like to sleep very late. So the morning individuals, they have an advantage on the BMI compared with the evening ones, because if you stay awake for longer at night, usually you ended up like bite some snacks and eating more junk food, and you ended up having a higher BMI. Late sleepers consume 248 more calories per day, with the excess of calories occurring after, like at dinner and after 8 p.m., like I said. So if you ended up sleeping later than your normal time, you ended up eating more food. So that's the average, like 248 more calories than if you sleep like earlier. And this happens usually later, like after 8 p.m. So this is a very nice graph that I like, because it just shows you like, so what happened, right, is the cycle, the vicious cycle. So insufficient sleep. So you're going to have feeding behavior, right? So upregulation of appetite is stimulating hormones. So basically, if you don't have enough sleep, you're going to be more hungry. And then also the rewarding of the food. So you're going to be exposed, or the reward is going to be better if you eat more carbs and sugarish food. And then what is going to happen? Your energy intake is going to increase and fat gain. Same thing on the other side. If you don't sleep enough, you're going to be tired, fatigued, you don't have energy. So then you're not going to do your physical activity or exercise to burn all these calories. Your energy expenditure is going to decrease and the fat gain. So it's just a vicious cycle. If you don't sleep well, you don't do a lot of physical activity, you ended up eating more, especially if you sleep at night, and then starts all over again. Okay, I believe that's our last one. So is this a myth or a fact? There is no relationship between breastfeeding as an infant and obesity. So is a myth. So breastfeeding actually can reduce the risk of obesity. So the rates of obesity are significantly lower in breastfed infants. There is a reduction of about 15 to 30% in adolescent and adult obesity rates if any breastfeeding occur in infancy compared with no breastfeeding at all. Each month of breastfeeding is associated with a 4% reduction in risk of obesity. And breastfed infants are more likely to self-regulate intake volume, which affects adult weight gain. So when I have that information for my patients, like, of course, that's the evidence, but I don't want the mothers or anybody feel bad if they're not able to breastfeed for whatever reasons. It doesn't mean that you're going to have the obesity if you don't, but if you do, you have a lower risk. You can have obesity also, but it's just a lower risk, like 15 to 30% lower in adolescent and adult. So you're going to have this decrease in obesity rate. Now, the main important thing is the self-regulation, right? So if you give the breast milk in the bottle, is not the same, because the bottle is there, they're going to drink as long, once it's done, okay, they are done. With the in the breast, they are able to have this self-regulation, and that's what is very, very important for the kid, and when this kid become an adult. So it's not just about the breast milk, which has so many benefits, but it's about the breastfeeding that regulates them. So the American Academy of Pediatrics recommend, of course, as we know, exclusive breastfeeding for about 6 months. I have like, there's so many people that go like, this is the minimum. And then you can go usually around 1 to 2 years. That's the average. So after 6 months is just like as like you can do, of course, and is recommended, but then you need to also start some solid foods. So then the baby start having also that experience with the little bit of solids. But you can continue, like I said, so you can continue like for a year or longer. I have friends that they are like, the kids are 2.5 years old, they still breastfeeding for comfort, they're still breastfeeding for especially when they want them to sleep, or just have that bound, and that's totally fine. But the first 6 months is so important, and that's when we're gonna have and we're going to see that obesity effects about the self-regulation. So these are my references, and yes, thank you. And I don't know if you guys have any questions. I'm happy to answer them.
Can I?
Hi,
Yes.
do you have any questions?
Yes. Hi, Dr. Ecler. This was a very good presentation, practical, something which, I'm going to definitely take home for my patients. And not only, but also for me and my family members. What about that? But something which I've always been curious about, and I think Annette will also maybe help me with this. So with children, obesity is a relative thing because it's calculated based on the percentile. In other words, if every child in the world gains weight, then they push the obesity level even to another point. So someone who is obese today may not be obese in 10 years or vice versa for children. So I guess, does obesity therefore predict the same conditions? So is it predictable also for children as it is for adults with regards to the medical problems that it causes? Because I'm just imagining, if it's relative, there should be a certain point where if you get to this point, then you have a high likelihood of having that disease or not having it. But if it's as compared to someone else, it makes it a little bit more challenging, isn't it?
Yes, definitely. And what we are seeing, especially here in the United States, like, you have no idea how many kids have obesity or severe obesity that I'm seeing in the clinic. So I think we are getting, unfortunately, to a point that the majority of the kids that have obesity or severe obesity, they carry that as an adult, even though not necessarily they will, but the chances are very, very high. What we are doing right now as part of the screening, as part of our training obesity medicine, starting at 2 years old, if they have a percentile more than a BMI percentile more than 95, we already start ordering labs. And you have no idea how many kids of 3, 4 years old already have high triglycerides, high A1C, high cholesterol. Okay. And that's the moment that we need to act, like, hey, parents, if we don't do, if you don't change the lifestyle, if we don't start doing something right now, that's just going to be worse. I have 12, 16 years olds with A1C of 10, 12.
Oh.
And that's the time that we need to do something, right? Well, actually past the time already. They are diabetics already. But that's why it's so important to act earlier. If we are able to do all these changes on the diet, on the physical activity, with the help of a dietitian, whatever help you have in your clinic, that's going to be significantly important for them when they become like young adults and adults. But it's like, you're right, but we are seeing a pattern that it just carries on your adult life.
Mm-hmm. And Annette, you're muted. Annette, you're muted.
What I also want to say, I'm working in a peds ICU. You won't believe how many children are diabetics already. How many of them their blood pressure are higher than mine.
Yeah.
And did you realize, I want to ask in the group of other cultures in other countries, did you realize that people's albumins are so low, but they're obese? And this is what we see in Saudi. I never gave in my life so much potassium, magnesium, phosphate, and also albumin. And still these people are obese. The children are obese, and they live in a time where they just, everything is instant. So they will order McDonald's, Kentucky, roasted, all those things. And if I go to the shops, they've got everything here. I must tell you, they've got everything, but they don't cook. Go look at the restaurants. If you look at the restaurants in the rest of the world, I heard the other day in France, they actually closed some of the restaurants and the coffee shops. Not in Saudi. In Saudi, everything is open and it's always full. So what are we feeding our children? And what was very, very nice, what you just said, is the self-regulation, because sometimes the mother can't breastfeed for some reason. And we said the breast milk is good enough. But what you said is, yeah, breast milk is good enough, but we need the self-regulation thing.
Exactly. That's why we incentive so much the breastfeeding. And as we women that have kids, we know that it's not easy. Nobody tells us, but I know it's not easy, but it's so worth it, because of that. Is the benefit of the breast milk and also the self-regulation. But you're right, it's just unbelievable the cases of obesity, severe obesity we have in our clinic. And he's just eating junk and sodas and juices, and it's just easier and it's tastier, but it's just the consequences we are seeing right now is like people with like kids with A1C of 10, 12, we need to act. We were supposed to act even before that. They already reached the diabetes, but that's kind of our go in the clinic and open an obesity clinic to see what happens.
Mm-hmm. Wow. Okay. So, and one of the things, I don't know, how do parents welcome you telling them about obesity in their children and possible consequences? Because I know I think it's the way parents take them is very culturally different, I would believe.
Yeah. Well, and all the kids that have the obesity or severe obesity, the parents have it too. So when they go and talk to them, like, of course, sometimes they feel embarrassed, sometimes they don't feel comfortable because it's an issue that they are going through. But that's the time to work as a family. And that's why I approach them. It's like, hey, you know, uh, this is an issue. It can have consequences for all of you guys. So is the time to work as a family and do these changes. Everybody's supposed to do the changes, the parents, the kids. And that's maybe the only way that is going to work, because if the parents, they don't understand, or usually some, not necessarily they're going to have diabetes or high blood pressure medical problems, but I said, like, it's just a matter of time, and you don't want your kids to go through all these things that you are going through right now, because even though they maybe don't have medical issues, I'm sure they have psychological problems like depression and low self-esteem because of the weight. So they're like, oh yeah. So when they kind of go like on that way, like, hey, we don't want your kid, to have any diabetes or high blood pressure. I kind of go to like the problems that they can have being on insulin and things like that, and they're like, oh my goodness, no, I don't want that for my kid. So when I think is your kid maybe has a greater impact than yourself, so and I said, let's do that as a whole family and we can do this. And they're like, yes, of course, yes. So they are very acceptable. I think it's all depending on the way that you approach. There was one father that told me like, but I don't want my daughter to be like these models. I was like, no. We're not talking about models. We're not talking about being skinny for other people. I'm talking about avoiding having medical issues in the future. I said, I'm not talking about that, so I don't go like, I want you to be skinny or fit. No, that's not my approach, because it transmit the wrong message.
Wow.
something else that I also want to say, what I see here, it's an instant thing. They don't want to take the effort into losing weight or actually live a little bit more healthier. They will immediately go to bariatrics. And with bariatrics, you know that the absorption is a problem. They all have a problem with their stomachs afterwards. And then 16 years old, 17 years old, 19 years old go for bariatric surgery, where they could actually have a change of habits. Because this is all what it's all about. If you look at what they eat, if you go to the shops and you look what's in that trolley,
Yeah.
I never saw so many cakes and pastries in my whole life. And it's from the morning till the night.
And again, bariatric surgery, like, yes, it helps, makes you lose weight, but you need to do the lifestyle changes anyways. They tell you in the beginning, like, if you're not able to have a strict diet, to change your lifestyle, you're gonna gain all the weight back, you know? So if you don't do the changes, even with the surgery, it's not gonna be successful. And I think, like you mentioned before, culture. So there is some things with culture, like some parents are like, I want my baby fat because then it shows that it's healthy, it shows that I'm, you know, that I'm giving enough food. So there is this issue with some cultures, and it's so true. And we just need to educate them that, like, you know, I understand where you're coming from. My grandma, I think, was maybe the same, you know, just like chubby, so you're healthy, but that's just not the reality. You know, even with babies, sometimes we need to, like, hey, let's slow down how much milk you're giving, or how much food are you giving? Are you guys, what are you giving? Juices? No, let's hold off, give some water, you know, so things like that. So even with babies, and we have sometimes this barrier with the culture for sure.
That's awesome. Thank you very, very much. That's super informative. Are we going to have your slides?
I can send my slides. I can send to the email that I'm communicating. Yeah, I'm happy to.
Perfect. Thank you very much.
You're welcome.
Yeah.
Have a good day.
Thanks a lot. You too. Thank you.
Sorry, I must say this was very formative, and I learned a lot because I'm also a diabetic educator, and we teach people to do the carb counts. You know how difficult it is. Now you go to the tin and you go and look how much total carbs there is, and it's very important. And this talk was great because it makes you more aware of where are we going with our obesity. And thanks a lot. It was informative. We will look for your slides. Also, it's going to be on YouTube, every presentation. Sometimes I like to go over it again, just to understand a little bit better. But thanks a lot for your presentation.
Oh, of course you are. And Annette, let me tell you, so you're a diabetic educator. So, well, this is just a FYI. So my daughter of 3 years old was just diagnosed with diabetes type 1. So I know exactly what you're talking about. So not diabetes type 2, but diabetes type 1. So it's not totally different story, but I hear you about the carb count. It's not easy. So that's another example that I give to my patients. You're like, hey, my daughter didn't have a choice. You do. So let's check, you know. So you know, she has an autoimmune disease. It's not because of her diet, but you have a choice. So let's do this together and don't take this insulin anymore, you know?
Yes. And the thing is education. That's the most important. And people, especially the younger generation, yes, they are wild. Sometimes I can just shake my head, but they're more accepted to what you say to them than the older people who are set in their ways. And my mother and my dad, this. So yeah, let us see. But thanks a lot.
You're welcome. You're welcome, guys. I hope you have a good day, okay?
You too.
And you too. Thank you. And good luck with your daughter.
Thank you. Yes, we are hanging there.